presentes en este nuevo webinar. Se me fue, no, se me ha ido la pantalla. Bueno, tenemos este nuevo webinar con la doctora Comela, va a ser de Distonía. De pasada, les recuerdo de nuevo el programa del CINS, que va a ser del 26 al 31 de octubre. Tenemos ahí las charlas del lunes, martes con neuroinmunología, cefalea. Tenemos también las charlas de neuropediatría que son del lunes. El miércoles, esclerosis múltiple. Jueves, viernes tendrán otras charlas más que van a ir presentes. Les vamos a mandar toda la información, ya, porque vamos a tener también vascular, neurocrítico, neuromuscular, trastorno en movimiento. Y como saben, la inscripción va a ser sin costo. ¿Ya? Les va a llegar toda esta información a sus correos, así que ya se han inscrito a estos webinars. Así que vamos a estar contentos de tenerles para el Simposio Internacional de Neurología de Santiago en su versión online. Los dejo ahora entonces con Mireia Balart. Mireia es neuróloga de la Clínica Dávila, se dedica a trastorno del movimiento. Ella va a presentar a la doctora Comela. Los dejo entonces con Mireia, que va a hacer una presentación breve de la doctora Comela y luego viene la charla. Gracias.
Hola, buenas tardes, ¿me escuchan?
Sí.
Sí, ya. El webinar de hoy día vamos a hablar de distonía. En realidad es la doctora Cintia Comela quien nos va a hablar. La doctora Comela, ella es licenciada en bioquímica y profesora emérita de neurología de la Universidad Medical Center de Chicago. Experta en todo tipo, no solamente distonía de trastorno de movimiento, pero también en trastornos de sueño. Y hoy día vamos a hablar de un tema bastante frecuente en la consulta neurológica, especialmente en trastornos del movimiento, que son un movimiento involuntario bien específico, que son las distonías. Vamos a ver las clasificaciones y los eventuales tratamientos que hay, tanto en las generalizadas como en las focales, las primarias o las secundarias. Les queremos pedir, por favor, que las preguntas y respuestas las hagan a través del chat y donde dice pregunta y respuesta. Por otro lado, existe la posibilidad de que esto lo puedan ver con traducción al español. En la pantalla ustedes miren abajo a mano derecha donde dice interpretación y ahí pueden optar a español. Y por último, al finalizar les pedimos que si pueden contestar la encuesta de evaluación de la actividad, que solamente les tomará 1 minuto y que permite mejorar o repetir o dar sugerencias a toda la actividad con respecto a este webinar o a futuros webinars. Good afternoon, Dr. Comela. It's a pleasure to me to introduce you to all Chilean neurologists. You can start if you want.
Thank you. Let me share my screen.
Sorry, I didn't introduce in English. But I
oh no, that's fine.
Spanish. Yeah.
My apologies.
Don't worry, we have enough time here.
I can't seem to find the slide. Oh, for heaven's sakes. Oh, it's right, I see. It's being hidden. There we go. Oops. Oh my,
yeah,
I made it. Yeah. First of all, I want to thank you sincerely for inviting me to present to you. It's one of my favorite topics, dystonia. Obviously, technology is not one of my favorite topics, but perhaps I will learn someday. We're going to talk today about dystonia, both the diagnosis as well as the treatment. My disclosures are at the bottom. First of all, I think it's important to understand that dystonia is a rare disorder. Generalized dystonia, really 4 to 50 per million. Focal dystonia, meaning dystonia in one place, one body region, is about 10 times more frequent, with neck dystonia or cervical dystonia being the most common seen in clinic. So I'm going to run through some videos because I want to demonstrate. Definitions are fine, but it's much better if you can see it instead of just hear about it. So dystonia is a syndrome. It's not really a specific disease. And it consists of involuntary, relatively sustained muscle contractions. You can see in this gentleman how his shoulder goes up and it's sustained and his head goes to the side. This is involuntary, but what you'll notice is it's repetitive and it's patterned. There's a movement that you can predict what's going to happen. So although it's coming in spasms for this gentleman, it is patterned, a pattern movement in contrast to chorea, which is unpatterned. Now in dystonia, unfortunately, remissions are very infrequent. And even when they do occur, there's often a recurrence. Let me show you a little bit more phenomenology. One of the most interesting things about dystonia is how it changes. And it varies with posture and it varies with activity. So in many patients, although there is paradoxical, it'll be triggered by a movement. This gentleman is playing his tuba, and you can see he's playing it poorly because his lips are dystonically pulling away. So it's called Umbroshur Dystonia. There are many types of musicians' dystonia and many types of action dystonia. So violinists can get it, pianists can get it, and typically people who practice quite a bit, they are more at risk for getting this type of dystonia. The other really interesting part about dystonia is that there is this phenomena that's called the sensory trick. It's also called the geste antagoniste. More recently, they've called it the alleviating maneuver. What you'll notice is this gentleman has severe involuntary cervical dystonia to the left. He touches his chin, it goes away. Now here he looks like he's just thinking. He's walking pensively, holding his chin. But once he leaves loose of his chin, what you're going to see, he'll fight it, but the dystonia is going to recur. And see how severe it is. So just the touch can alleviate the symptoms. Sometimes even just imagining the sensory maneuver can alleviate the symptoms. Now, as with everything, we like to classify things. And in 2013, a new classification scheme for dystonia was published by Alberto Albanese. And he divided it into two axes. Axis 1 having to do with the clinical features, axis 2 having to do with underlying etiology. So clinical characteristics, first looking at associated features. So there's a phenomena called isolated dystonia. We used to call it sporadic or idiopathic, but it's now called isolated, where only dystonia is present, with the exception of tremor. So you can have tremor and still be an isolated dystonia. Combined dystonias are dystonia combined with other disorders. Let me just show you a case. This is a young woman. She has a history of tremor, in quotation marks, in her family. It was called the Toomey tremor, in fact. And what you're going to see is you'll see the dystonic posturing of her hands, but also she has spasmodic dysphonia, and she has head turning. As long as as well as hand. But she's also got these very quick jerks that you'll notice predominantly in her hands. So she's actually an example of a combined dystonia, and she's myoclonic dystonia, myoclonus dystonia, which is DYT11. Epsilon glycan is the abnormality. So this is an example, a nice example of a combined dystonia. We also classify dystonia by its age of onset. And this gives you from infancy to late adulthood the different classifications that we use. And you'd say, well, why is this important? And I'll get to that. Finally, we classify it by distribution. This is focal dystonia. She only has dystonia involving her neck, nowhere else. This is segmental dystonia, which means two contiguous body areas are affected by the dystonia. And here you can see the eyes and the lower face. Here you can see the neck and the trunk along with an arm. And then generalized dystonia means just what it says, dystonia all over, in fact. Now, why is this important? Because it does help you in many ways. So when you look at the age of onset and where the dystonia begins, what body region is affected, what you'll see is in children and young adults, it begins predominantly in the leg. It never begins in the face for a primary or isolated dystonia. Now, when you get up to the older adults, what you see is it never or very seldom begins in the leg and often begins in the face and the neck. The arm is kind of a constant amongst all of them. When you look at spread of dystonia, so spreading from one body region to become potentially generalized dystonia, what you can see is in the young person, they have a high chance of developing generalized dystonia, i.e. a poor prognosis. When you look at adults, they usually get dystonia in one body area and it stays there, it stays focal. It may become segmental, but for the most part, it stays focal. So when you see a child with a leg dystonia, you know the prognosis is likely to be generalized. If you see an adult with a neck dystonia, it's very unlikely that they're going to spread to become generalized dystonia. So they have a much better prognosis insofar as spread. So axis 2 has to do with etiology. What is underlying the dystonia? So these can be inherited, acquired, or idiopathic. And I'm going to show you some of the inherited, one of the inherited dystonia. There can also be nervous system pathology. Here you see a pecan patient with the eye of the tiger sign who has dystonia as one of his predominant manifestations. But this is a little girl who we actually found on child psychiatry. She was laying in the doorway and she had all of these movements. Now it started in her leg when there was problems at home. And as the problems increased, her dystonia seemed to spread. So they believed that she was functional or psychogenic. When I saw her, it's clearly dystonia. And you can tell there is that patterned movement. She cannot really suppress it. She's got tricks she can do to improve it, but for the most part, the dystonia is where it's at, and it meets all the criteria, patterned movements. Now, she is an example of a DYT1, the first genetic form of dystonia that was described. And it was described, boy, in the 80s, late 80s. You can see that it's more frequent in Ashkenazi Jewish than in non-Jewish. It begins in childhood, typically in the leg, onset in the limb, over 90%, and over half of these kids generalize. Now we know that the mutation is a GAG deletion on chromosome 9, and we know the abnormal protein is torsin A. but we have not yet been able to come up with a way to prevent this particular mutation. So this just to demonstrate all of the genes that, and I am not going to read this, but there are many, many genes that have been described that underlie dystonia, even when it's just dystonia. And you can see that many of them are autosomal dominant, and you can see that many of them have their onset in childhood, although there are a few with adults. Not all of those mutations have been described. Now, when you look at the combined dystonias, likewise, there have been many genes that have been described for this. Dopa-responsive dystonia in particular is one that we should be aware of. Typically, it combines a diurnal or a circadian pattern of dystonia, better in the morning, worse in the evening, and it is inherited. And this dystonia is easily treated using low doses of levodopa. So that's why we always think about that one whenever we're thinking about dystonia. What are the red flags for atypical dystonia or secondary dystonia? Well, I've already talked about one. The site of onset is atypical for age. So an adult who begins in the leg or a child who begins in the neck or above, that's a red flag that you're dealing with something besides dystonia. Onset at rest, so it's not triggered by action, it's not a dynamic movement. Psychological findings in addition to dystonia to suggest perhaps a functional component to it. Dystonia on one side of the body, solely on one side of the body, typically reflects a lesion in the contralateral basal ganglia or its outflow. If you have a history of some sort of etiologic factor, birth anoxia, there is dystonic cerebral palsy, or exposure to dopamine receptor antagonists, there is tardive dystonia. Any abnormalities on CT and MRI, again, takes you out of the realm of a isolated dystonia and into the realm of a secondary dystonia. And then all of the things that can suggest a functional disorder as well. I'm just going to run through a bunch of dystonia because I think this is the best way to learn about dystonia. You see it. This woman has blepharospasm. She's got lower facial dystonia. We used to call this Mej syndrome. We now call it craniofacial, but she's the right age. Now this is a woman who's 19 and she's got blepharospasm, lower face dystonia, but the wrong age. And in fact, she's a Mercado-Joseph's disease. So she did not have an isolated dystonia. This gentleman, a perfect example of an adult onset cervical dystonia. Head is turning to the right. He's the right age, and it's classic. This gentleman I show you, he's a little young, but he has an isolated dystonia, but I wanted you to see his tricks. So that's his sensory maneuver, a toothpick in the mouth. There's a million of them that people will use. Now, what's wrong with this? Well, this is a little girl with cervical dystonia. She came in for botulinum toxins. Her dystonia was very painful and fixed. She actually had a C1, C2 subluxation. So she had a skeletal abnormality. This is a beautiful example of writer's cramp. You can see as he writes, his hand cramps up. So he has to get it loosened up. But again, when he writes again, it happens again. This is our red flag of a fixed dystonia. So as much as he tries to fight it, that dystonia is fixed. He had a contralateral AVM of the basal ganglia. So again, another clue. This is the child who fooled me because his dystonia didn't have it. It was patterned, but it seemed fixed and it seemed unusual because there's no twisting or torsion component. But he went on to develop generalized dystonia and was BIT1 positive. This woman, she has dystonia. Watch the variability. There's a lot of variability in her. One eye closes, then the other eye closes. This is suppressible, worse under stress. And in fact, she's an example of a functional dystonia, psychogenic dystonia, functional movement disorder. That's not always easy to distinguish. And movement disorder specialists have disagreed about, this is functional and this is not. Watch this child. He gets up out of the chair. That sudden exertion causes this dystonic, painful dystonic posturing of a side of his body. He's got a paroxysmal kinesiogenic dyskinesia or dystonia. That's easily treated using things like carbamazepine and other anticonvulsants. But you have to recognize it in order to be able to treat it. This is a lovely example of a foot dystonia. I want you to see what happens as she walks backwards. The dystonia disappears. It is very action dependent. This is not a functional dystonia. It's a true dystonia. I think I'm going to take us on from there. I'll run out of time here. I just want you to take a look at this lady, because this is the one that you may get, people say, well, I'm not sure what this is. So she comes in because she had trouble walking, and it started in her teens, her mid-teens, and it's been slowly progressing. Now she's, I think she's 19, and you can see, you don't see anything in her face. You don't see much in her hands. There's no tremors. When she puts her hands together, you'll notice a little bit of spooning right here, but it's hard to tell. But her problem and complaint is walking. It's lovely to see no bradykinesia, isn't it? So as she stomps her feet, you can see just a little bit of posturing of her toe. On this side, you see a lot more posturing of the toe. But again, that's not her complaint. Her complaint is walking. And this is her gait. Now you have to think to yourself, well, if I saw someone like this walking down the street, what would I think? But what I want you to notice, it's a patterned movement. It's always the same movement. But it only happens when she's walking. It's action-induced. It's a gait disorder. Watch when she walks backwards. It goes completely away. This is a true example. What this young lady has is DYT1 or inherited dystonia. And that's the typical dromedary gait that we see associated with that kind of dystonia. But pretty impressive, so you can see why it can sometimes get confusing. Let's talk a little bit about treatment. I always like to start with non-medicine, non-pharmacologic treatment. This lady has a dystonia of her neck. See what makes it better? Putting her arm over her head. And she's fine. Now her problem is that she likes to drive. And you need both hands to drive. You can't just hope for the best with one. So she developed her own, if you will, sensory trick in order to be able to allow her to drive. I call it the purse gest. She puts the purse on her head. That's her trick. Her head is straight, and now she can use both arms to drive. She doesn't need any of these other things we're going to talk about, unless she wants them, because functionally she's fine. She just wanted to know what she had. But let's talk about some of the others. So standard treatments, I can't tell you enough how useful having an occupational or physical therapist do an evaluation. They have their own tricks that I can say I certainly don't know. And sometimes they find just the trick that's right for the individual. We're going to look at some oral medicines, botulinum toxins, and a little of DBS. So oral medicines are really quite disappointing for most forms of dystonia. Here you can see that the cholinergic system is often manipulated, but it's limited because of the side effects that result from these drugs. The GABAergic, baclofen, clonazepam were used. Tetrabenazine, too many side effects, too little benefit. Other agents that have been used, I put carbidopa, levodopa first because I want you to remember about dopa-responsive dystonia, where small doses of levodopa can actually almost be curative. You have to continue it throughout their lifetime, but it's what I view as a wonderful way to approach dystonia. There are no oral medicines that are approved that have FDA approval for dystonia. What's the problem? Why haven't we come up with something better? Our problem is that we don't know really what the underlying pathophysiology of dystonia is. Currently, what we're thinking is that it's a network disorder, so that there is more than one area of the brain that has interplay into the pathophysiology of dystonia. And here you can see normal movements. There can be a one-hit, let's say the basal ganglia. There could be miscommunication between two nodes, or there could be a two-hit hypothesis, two areas of the brain acting abnormally. Let's say the basal ganglia and the cerebellum, as an example. And the reason I bring that up is because the cerebellum has been implicated in the pathophysiology of dystonia. We used to think that the basal ganglia and the cerebellum had parallel pathways to the brain, but they don't. They interact with each other. Here you can see the dentate nucleus through the thalamus up to the striatum. And here's the subthalamic nucleus through pontine nuclei going to the cerebellar cortex. So they really are, it's an integrated circuit. So one can imagine if one thing goes wrong in one, you can get dystonia. If there's a miscommunication, you can get dystonia. Or if something goes wrong in both. Now this just points out, this is the basal ganglia right here. And this is a close-up. And here's that cholinergic neuron, interneuron, makes up about 5%. And you can see that it has both effects on the indirect pathway and the direct pathway in the basal ganglia. So it modulates really in many ways the output of the basal ganglia. We have always said there's a balance of cholinergic and dopaminergic modulation, and that acetylcholine really has very powerful influences on striatal dopamine transmission. So if you get imbalanced cholinergic transmission, perhaps that is the pivotal point, particularly in some of the inherited forms like DYT1 dystonia. So there was a study done, and this study is now getting to be older. It was done in 2017, that looked at the strength of cholinergic tone in dystonia. And it looked at it in mutant knock-in mice. So you had your wild-type mice, which were TOR-A++, and then the DYT1 knock-in mice, which had the delta E+. What they did is they implanted a microdialysis cannula near the striatum, and they first sampled for basal levels of acetylcholine. And then they sacrificed the mice, and they evaluated brain slices using a cholinergic patch clamp. What they found in this baseline, remember when they first drew out from the mice, that the baseline levels of acetylcholine tone were elevated in the cannula, in the knock-in mice. In the DYT1 mouse, there was a higher level of acetylcholine. And then they thought, well, let's see how this all reacts. So this is your wild type, the AA, the plus, and this is your knock-in. And what they did is they activated D2 receptors using quinpirole. And here you can see when they injected the quinpirole in the wild type mice, the firing rate of the cholinergic neurons went down. Here we have our knock-in mouse, and what you can see is when the quinpirole, when you activated D2 receptors, it actually paradoxically went up. And this suggests that there is an excess of cholinergic tone that may be playing a pivotal role. So they thought, well, let's try some dopamine, some acetylcholine antagonists like scopolamine. And this actually reversed the D2 receptor stimulation paradoxical excitation in the TOR delta E plus mouse. Increasing cholinergic tone using neostigmine in the wild type mouse caused the same paradoxical firing that you saw in the abnormal mouse. So it does suggest rather strongly that there is a pivotal role for cholinergic tone. Let's look at some other therapeutic targets. So we've identified one, acetylcholine. This is the cerebellum. And here you can see the AMPA receptors play a very strong role in the cerebellum. The studies that have been done have suggested in at least animal models that the cerebellum is associated with dystonia through glutamate receptor activation, AMPA receptors. Not only that, but if you use an AMPA antagonist, you can alleviate that glutamate-induced dystonia. So that led to this study of perampanel, which is a selective, non-competitive AMPA receptor antagonist. So it reduces glutamatergic signaling. It is already FDA approved, and we are now looking at it in dystonia to see if potentially it could provide us with another target, if you will. Let's now turn to a more standard therapy. So oral pharmacology, we have not come a long way. Botulinum toxins, we've come quite a long way. It's the most potent neurotoxin known. There are now 8 serotypes. I used to say the A through G, but include X. But only A and B are available for human use. I think you all know how it works. This is the molecule in its original structure, and this is a cartoon which shows the heavy chain, which is connected by this disulfide bond to the light chain. The light chain is the neurotoxic moiety. So what the heavy chain does is the carboxyl terminal recognizes specific acceptors on the nerve terminal, which results in endocytosis into a vesicle of the botulinum toxin molecule. And then the heavy chain also forms a canal, if you will, and boots the light chain out. Now here we have the light chain, which remember is an enzyme that breaks up protein. And you can see that what it does is it breaks up those proteins that are responsible for fusion of this membrane with this membrane. You don't get acetylcholine release, and you see this is the muscle. Without any acetylcholine, the muscle is paralyzed. And that's really the underlying mechanism, or so we thought, but does explain the muscle weakness that arises following injection. Here you can see the 2 available types. Type A cleaves SNAP25, so the light chain cleaves SNAP25. Type B cleaves the vesicular-associated membrane protein, or VAMP. So despite there being all these serotypes, they all act differently. They don't act the same way. They're pharmacologically distinct insofar as which of the snare proteins they're going to act on. Now, I said it's not the only thing. So right now, we also think that there may be a peripheral effect that we've already gone through, but that central effects are also very important, carried through muscle afferents, which may normalize altered brain network activity and have even been shown to normalize the left-right asymmetries of the white matter microstructure. that one sees in dystonia. Now we know you recover from botulinum toxin. And the way you recover, so this is the nerve and here's the muscle. Nerve forms sprouts. These sprouts go on to form neuromuscular junctions, but then they recede. And you get back the original neuromuscular junction. However, you can see denervation persist up to 1 year following injection. So it's not immediate. And that's why it's so useful for cervical dystonia and the other forms of dystonia. These are the currently available types. Now this is in the United States. The Anabot, Ablebot, Inclebot, and Remabot. So these top three are all type A, and it's the same, it's the Hall variant. So they're all the same. They are prepared differently, purified differently, and have different dosings. Remabotulinum toxin type B, it's the only type B, the serotype B that we have. We don't usually start out with type B. We usually start out with one of the type A's. The choice is whatever toxin type A that is available and that you're comfortable using. The number of different disorders that have been treated with botulinum toxin are innumerable anymore. And it extends far beyond dystonia. It started with dystonia, but it extends far beyond. There's GI disorders, GU disorders. It's been used in tremor. The variety of uses for botulinum toxin are really quite impressive. These are practice guidelines for the treatment of cervical dystonia, blepharospasms, spasticity, and headache. And these were an update. This was done, I think it was 2016. This was an update, but it needs updated again. We're farther along than even this report. So I think in conclusion for botulinum toxin, I think it was really one of the main therapeutic steps that we were able to take, that we could finally do something about dystonia, particularly focal dystonia. So if you inject a muscle and make it weak, and it happens to be an involuntarily activated muscle, that weakness allows the patient to restore to a more normal head posture. And here you see this poor woman who's got cervical dystonia with a really quite severe tilt to the right. She's also got a shift forward. She has a lot of pain associated with this dystonia. After injection, she looks lovely. If you inject the correct muscles, you need to inject the right muscles. Will this last? No. She will need re-injection at approximately 3 to 4 month intervals in order to be able to maintain this benefit. So it is still not, we're not perfect yet. And I think patient satisfaction demonstrates this. So what this shows, this is a measure of severity, or the Twister score, that looks at cervical dystonia. And this is the rating of patient satisfaction. And what you can see when the toxin is at its optimal, so that's usually about 6 weeks to about 10 weeks after injection, patients are very satisfied. But as it wears off, their satisfaction decreases by half because they're getting their symptoms back. And so this suggests that the toxins we currently have don't seem to pull us all the way through insofar as patient satisfaction. There's a new type of botulinum toxin, daxibotulinum toxin, which is specific in that it has an extra molecule attached, which makes it stay longer at the place in which it's active. And here you can see with this toxin, you can get an effect. This is an open label study, big caveat, but you can get an effect that can last as long as 24 weeks. This toxin is currently under under study. There's a clinical trial currently going on, but it would be lovely if it does work out, because it would provide our patients with a duration of benefit that may be twice as long as what we currently have. There are also advantages to having a short-acting toxin. So type E is currently being studied for use in pain, acute pain, for use in wounds so that wounds don't gape apart. And why is that? Because it has a really fast onset of action. So it starts working within a day, but then it wanes within 2 to 4 weeks. So not only can you see that this could be useful for all of these other like pain, et cetera, but it could also be useful as a way to test the pattern of your injection prior to giving a longer acting toxin. And finally, we come to DBS. So besides botulinum toxin, Dbs Gpi Stimulation is the second major therapeutic advance we have made in dystonia. It's very effective in isolated dystonia. Its benefit is sustained, but it's not perfect. It has to do with lead placement, battery usage, and many other complications that can occur during surgery. So although it is almost miraculous when you see these kids with this generalized dystonia, they get DBS and they become almost normal children unless the DBS malfunctions. And that goes on into adulthood. But on the horizon, there's going to be newer leads, additional contacts. We'll be able to directionally path our stimulation. So it won't just be with the fixed pattern we have now. We'll be able to do better imaging to find the most optimal site for placement. And hopefully in the future, we'll develop adaptive DBS techniques, which can actually stimulate when the stimulation is needed and not when the stimulation is not. So I think what I'm trying to say is that for dystonia, we have made major advances, but we have not cured dystonia, nor do we have really as satisfactory treatments as I would like to see. But there is a lot of hope on the horizon. And with that, I'm going to end, and I'm going to thank you all for your attention. And I'll turn off my screen share now.
Thank you very much, Dr. Cornella. It's a great presentation for us. It was really clear. And we have a few questions. Maria Jose asks, how do you treat an acute dystonic movement? Usually
acute dystonia.
Yeah.
Acute dystonia is, if you're talking about like something that's the result of a dopamine receptor antagonist, you typically use the anticholinergic drugs to treat that. If you're talking about someone with an onset of isolated dystonia, naturally occurring dystonia, then you're going to go likely, if you can get it. The US is having problems because we have to get pre-auths now. And I used to treat these people right away, because to me, the faster you treat them, the more likely you are not to ingrain that dystonic abnormal sensory pattern that one sees on the cortex.
And I have a few questions that for Mike. What do you think about the gunshot to study panel genetic?
I'm sorry, I missed the question. I'm sorry.
Some people think that people is using gunshot to study dystonia, using a panel, genetic panel to study. What do you think about that?
You mean using like whole exome sequencing?
Yeah.
In order to.
Yeah.
Yeah. You know, I
actually, a small panel. When do you use that, or what do you do?
Well, the question is, when do you actually do?
Excuse me, I will ask in Spanish. ¿Están traduciendo en español, Jorge? No, ya. Le pregunté que cómo estudiamos esto, porque el gancho es como como disparar así, hacer un panel universal para tratar de buscar un gen. ¿Qué piensa ella de hacer eso frente a un estudio de distonia o distonía?
So currently, we only have a few mutations that we can test for on a commercial basis, if you will. DYT1, for example, DYT11. Whole exome sequencing, I think, is going to be the secret to precision treatment of dystonia in the future. Right now, we use it in patients in whom there is a family history. We use it in children, but mostly in patients in whom there is a family history. They're not any of the known genes. So that's how we have found all these new genes. That's why there's so many dystonia genes, because they turn up not infrequently.
Thank you. And another question is, writer cramps is usually easily to diagnosis, but the treatment is really hard. What do you do with the writer's cramp?
Writer's cramp is very tough. You have to really develop the expertise to be able to analyze what the dystonic movement is. Because a lot of the people that have a writer's cramp will also have a compensatory movement. And if you inject the muscles doing the compensatory movement, you're going to get a worse dystonia. Not only that, but often there's a weak hand. So you'll get weakness in the hand if you give too much. I always send people to the occupational therapist. Is there an adaptive device one can use so that this person can write? Is there a posture of the hand that alleviates the dystonia? Because as we saw with the lady in the purse, you have to explore it a bit. Finally, if it's severe, one would even consider doing things like DBS unilaterally. Unilaterally.
Thank you. And it's not more question? I don't see any more. We don't have more questions.
I have a question.
Much. Yeah.
Dr. Cynthia Gomela?
Yes.
Yes. Hi, sorry to interrupt. This is about a few patients we had that they consult the ER, emergency room, with some kind of dizziness or abdominal pain. And they were treated with, for example, metoclopramide, or they were treated with some ondansetron, some medication for gut movement, and they got acute dyskinesia. Did you ever hear that?
Yeah, metoclopramide in particular.
Yeah, metoclopramide. That
yeah.
These people, they may have some genetical problems with some kind of mutation of this known genes, or it's just an idiosyncratic reaction? What do you think about?
Well, you know, to me, everything's in your genes. So to me, there is some type of genetic predisposition for some people to get this dystonic reaction to drug, and others not, because you know, it actually represents a very small percentage of the people that are treated with metoclopramide. But we don't know the genes. We don't know which gene would make you more likely to have one of these reactions.
Well, it used to happen in the past with, I don't know the name in English, is Toican. It's a medication for dizziness.
For dizziness?
Yes. Well, I can't remember the name in English, but it was really frequent. Like 1 in 10 people, they get the facial and ocular dystonia, and it was withdrawn here from the emergency rooms many years ago. It was really frequent.
Was it a very strong
I don't know,
dopamine receptor antagonist?
Yes, it was.
Yeah, there you go.
Sorry, Ken. Okay. Thank you for your answer.
Well, thank you for the question.
And another one is, if you have a patient with a cervical dystonia and you use Botox and didn't respond the movement, but the pain was gone, is that possible?
Yeah.
Just the pain?
So for some reason, the botulinum toxin does treat pain exquisitely well. So sometimes you may not get as much improvement in the movement as you do in the pain, if the pain is due to dystonia. So sometimes pain in the neck is not due to dystonia. It's due to other musculoskeletal or some other reason. But for dystonia, injections into the painful dystonic muscle is really effective at alleviating the pain.
Yeah. And for next time, do you have to use more doses or no? It's independent.
It depends on how so with botulinum toxin, it's a treatment to improve function. So it really depends on how the person functions. So if you make a difference that's, say, 40% improved, they still have dystonia, but they're able to do what they need to do, even with that much milder form of dystonia, particularly without pain. So I think for the most part, it's really dependent on what you're using as your patient outcome.
Okay, thank you. I have another question, just a second, please. Oh. Maria Eugenia Jerez asked about the antibody nerves with the Botox.
Yeah.
What do you think about that?
Well, when we first used
neutralizing antibodies.
Yeah, that's right.
Yeah, neutralizing antibodies.
Yeah.
So when we first started using botulinum toxin, it wasn't very well prepared. There was a lot of protein. It was stored in a vial for many years. And the antibody rate was estimated to be about 20%. The antibody, not the antibody rate, the lack of response assumed to be due to the antibodies, to the neutralizing antibodies. What a recent article has described, a recent study looked at patients being injected with botulinum toxin. And in fact, the percentage, I think it was like 10 or 15%, developed some neutralizing antibody, but yet were still responsive to botulinum toxin. Overall, now we see much less in the way of resistance, if you will, due to antibodies than we used to back when we started in the late 80s. So it is of concern, without a doubt. You should do all those things that were always recommended. Try to keep the intervals as long as possible, the dose as low as possible. Do not keep rotating different brands. And then if they do get resistance to A, you can always turn to serotype B and hope that they will get benefit from B that will last for many years. Sometimes with B, you'll get benefit the first few injections, and then they develop antibodies to the B as well.
Okay,
yeah, resistance is not a good thing. Luckily, it's not a frequent thing.
And the last question, what can you tell about two things, about dystonic tremor, cephalic dystonic tremor?
Dystonic tremor?
Yeah.
That's a toughie.
Yeah.
So it's a little controversial. Some have argued that all tremor is dystonia. I don't think that. But I do think that there is an association, likely genetic, between dystonia and a regular, what we would call essential tremor. I do think there's that relationship. With a dystonic tremor, typically it's jerky. So you won't see the regular sinusoidal pattern that you see with ET, but you'll see this jerking kind of tremor. So those you can distinguish more or less. Although again, it's all by vision. So you have to have some experience with seeing both before you can really tell the difference. But tremor is a really compelling question, I think, insofar as its relationship to dystonia.
And the last one is, do you think, or pretty sure that hemifacial smile is not dystonic problem? It's a myoclonic dystonia?
The hemifacial is definitely not dystonia.
Okay.
The hemifacial spasm is a peripheral disorder involving one side of the face. It can have tonic and clonic components, and it can sometimes involve both sides. But it's a peripheral disorder of the facial nerve. Probably a phaptic transmission, treated with botulinum toxin, but not a dystonia. It doesn't start up here.
That's all. Thank you very much, Dr. Cornelia. It was a pleasure to me and for all Chilean people.
Well, and I want to thank Dr. Navarrete and Dr. Valacura for allowing me to participate in this session.
Anytime.
Thank you very much, Doctor, and we hope to see you here in Chile.
Oh, me too. I hope it's soon.
As you deserve. Okay.
Okie doke. Thanks so much. It was a pleasure. Bye-bye now.
Bye-bye. Thank you. Les recordamos que por favor, si pueden contestar la encuesta, que solamente les tomará 1 minuto y esperamos verlo para la próxima. Muchas gracias, doctor Villacura, doctor Navarrete. Y buenas noches a todos. Bye. No escucho nada.